Welcome to the Deep Dive. We're the place that takes, stacks of complex research and turns it into knowledge you can actually use.
And today we're tackling something really personal. It's often hidden, definitely emotionally challenging, but actually incredibly common.
We're talking about hair loss, specifically during the menopausal transition.
Yeah, and this isn't just a minor thing. It's often deeply tied to identity, to confidence. The numbers back this up too. Something like up to 40% of women notice significant hair thinning around perimenopause or menopause.
So if this is something you're experiencing, you're probably looking for clear answers. And, quickly. You need thorough knowledge on something that feels complex, but is surprisingly widespread.
Exactly. And our mission today is pretty straightforward. We're going to unpack the real personal cost of this.
We'll explore the science behind it, hormones, metabolism, all that.
Define the clinical conditions you hear about, like female pattern hair loss, and also the more severe ones like frontal fibrosing alopecia.
And critically, we'll review the evidence-based treatments. What actually works. We'll look at HRT studies, standard dermatology approaches, the lot.
Okay, let's get into it. Starting with that real-world impact, the emotional side of things.
It's significant, isn't it? The psychological distress.
It really is. Our sources consistently show women with pattern hair loss often report significant depressive symptoms. It genuinely impacts quality of life. It's really not just cosmetic for so many people.
No, it feels fundamental. It challenges your self-image, your confidence.
Absolutely. And that story of Elizabeth Carr Ellis really highlights this. She noticed her hairline receding at 47.
And her doctor initially just dismissed it.
Yeah, basically told her it was male pattern baldness, and she just had to, accept it, which was completely wrong.
That's awful. And it cost her time, didn't it?
6 years. 6 crucial years before she got the right diagnosis. It turned out to be frontal fibrosing alopecia, or FFA.
Which is much more serious.
Much more. It's aggressive, often irreversible scarring. She described not just the receding hairline, but, losing her eyebrows too. That detail really brings home how devastating it can be.
And that experience, that frustration with being dismissed and the lack of information, it actually spurred her into action, right?
It did. She was angry about menopause being this sort of taboo subject, even in medical settings. So she helped create the #KnowYourMenopause campaign.
Aimed at getting women informed earlier about all the symptoms, including things like hair loss.
Exactly.
Yeah.
Because getting that information and diagnosis sooner is key. But even beyond that, the psychological piece is huge. Finding support, finding ways to cope.
Like meticulous styling or maybe using hairpieces or wigs.
Right. Those coping mechanisms can be the first step in just feeling a bit more like yourself again, regaining some confidence while you figure out treatment.
Okay, so the emotional toll is clear. Let's shift gears now and look under the hood. What's biologically going on? You mentioned a shift in the hair cycle.
Yes. This is where it gets really interesting. We need to start with the most common type, which is female pattern hair loss, FPHL.
And how does that typically look?
It's usually about reduced hair density, mainly over the central part of the scalp. But crucially, it often spares the very front hairline.
So not like the receding hairline we associate with male pattern loss.
Generally, no. You see patterns like the Ludwig scale sort of diffuse thinning on top, or what's called the Olsen or Christmas tree pattern.
Christmas tree?
Yeah, where the thinning is widest right at the front near the forehead, and then it narrows as it goes back towards the crown. Kind of like a triangle or, a Christmas tree.
Okay, I can picture that. And that's different from the classic male pattern, the M-shaped recession and the spot on the crown.
Exactly. And the core mechanism in FTHL is something called follicular miniaturization.
Meaning the follicles shrink.
Essentially, yes. The hair follicles start producing hairs that are finer, shorter, and the growth phase itself, the anagen phase, gets shorter.
And hormones are driving this.
Primarily, yes. The shifts during menopause are the big trigger.
Okay, explain that mechanism. Because sometimes women get blood tests and their hormone levels look normal.
That's the crucial point. It's not always about high androgen levels. As estrogen and progesterone decline during menopause, you lose their protective effect on the hair follicle.
Estrogen keeps hair in the growth phase longer.
You can think of it like that, yeah. It helps maintain that long anagen phase. So when estrogen drops, even if your total testosterone level is technically normal, the ratio changes. Androgens become relatively more dominant.
Ah, so it's the balance shifting.
Precisely. And that relative androgen dominance, even with normal total levels, is what seems to trigger that miniaturization in susceptible follicles.
So does that mean standard blood work might actually miss the issue? if the doctor isn't specifically looking at that ratio, or maybe not using the most sensitive tests.
It can happen. You ideally need high-quality assays, especially for free testosterone, to get the full picture. But honestly, often the clinical pattern of the hair loss itself is the biggest clue to this shifting ratio.
And the prevalence really jumps after menopause, doesn't it?
Massively. It's relatively low in younger women, maybe 3 to 12%, but some studies show it in over 50%, half of healthy postmenopausal women between 50 and 65.
Wow. Okay. That hormonal link seems pretty clear. But you mentioned another idea, something more cutting edge about the follicle itself.
Yes, this is a really fascinating concept, the idea that the hair follicle might undergo its own kind of menopause, almost separate from the systemic hormonal changes.
What does that mean, follicle menopause?
It focuses more on metabolism. Hair growth is incredibly energy demanding and needs a lot of fuel.
Right.
And this theory suggests that as we age, the follicle itself might become less efficient at storing and using energy, specifically glycogen, which is like its immediate fuel reserve needed to kickstart the growth phase.
So the follicle runs out of steam, metabolically speaking.
Kind of, yeah. If it can't generate the energy needed for a robust long anagen phase, the hair growth suffers.
That really shifts the perspective, doesn't it?
Yeah.
It suggests we should maybe look beyond just hormones.
It does. It opens up questions about whether supporting cellular energy metabolism, maybe through diet or specific nutrients, could be important for hair health as we age, perhaps complementing hormone-focused treatments.
Very interesting. Okay, let's circle back quickly to frontal fibrosing alopecia, FFA, the condition that Elizabeth Carrel has had. That's different from FPHL, right? More severe.
Much more severe, yes. FFA is a scarring alopecia, and scarring is the key word here.
Meaning the damage is permanent.
Yes. Active inflammation destroys the hair follicle completely and replaces it with scar tissue. That hair is gone for good. It mainly affects postmenopausal women, causing that progressive hair loss along the front and sides of the scalp, and often eyebrow loss, too.
And is there a hormonal link there, too?
Well, it's strongly suspected. One of the mainstays of treatment for FFA involves anti-androgens, which points towards hormones playing a role even in this really inflammatory scarring type.
And we see that hormonal imbalance, that lower estrogen relative to androgens, show up elsewhere, too, don't we? Not just with hair loss.
We do, yeah. Facial hirsutism, getting more noticeable hair on the chin or upper lip that's seen in about half of postmenopausal women.
Even with normal overall hormone levels.
Exactly. It's another sign of that relative shift. Different follicles just react differently to that androgen dominance.
Okay, so if hormones are clearly involved in FPHL and maybe FFA, the big question is hormone replacement therapy. Can HRT fix hair loss?
The HRT question. It's nuanced. Overall, there isn't enough large-scale definitive evidence to say HRT is a guaranteed fix for FPHL across the board.
But it's not a definite no either.
No, not at all. There is a specific pilot study, quite interesting, on postmenopausal Japanese women with FPHL.
And what did that find?
It found that using estradiol replacement therapy did lead to a significant improvement in the appearance of thinning, especially at the frontal hairline. And maybe just as importantly, it increased the hair's anchoring strength. The telogen hairs were harder to pluck out after 6 months.
So for some women, particularly maybe with that frontal thinning pattern, HRT could help.
It suggests it could provide real benefits, yeah. Likely by helping to stabilize the follicle environment, counteracting some of that androgen effect. But it's not a universal solution based on current evidence.
Right. It really underscores that need for targeted approaches and proper diagnosis. So let's move into the actionable stuff. If someone listening is noticing thinning, what's the path forward? How do you get diagnosed?
Okay, first step. Diagnosis is primarily clinical. A dermatologist, ideally one with expertise in hair loss, will look closely at your scalp.
What are they looking for?
The pattern of thinning, comparing the width of your part line in different areas, maybe comparing hair density at the front versus the back. They'll use a dermatoscope, like a magnifying tool, to look for those miniaturized hairs we talked about.
And sometimes tests are needed.
Sometimes. A scalp biopsy might be done, especially if they need to rule out other things definitively, like chronic telogen effluvium, which is diffuse shedding, or a scarring alopecia like FFA or lichen planopilaris.
And what about blood work? Is that standard?
Absolutely essential. You must have blood work to rule out other contributing factors or things that could mimic FPHL.
What needs checking?
Definitely need to assess for androgen excess, and again, using high-quality tests for total and especially free testosterone is key. Plus, you need to check for common nutrient deficiencies that impact hair.
Like iron.
Iron, yes, specifically ferritin levels. Also zinc, vitamin D, thyroid function tests are crucial. TSH, free T4, free T3, and checking prolactin levels too. Gotta cover the bases.
Okay, so you've had the clinical exam, the blood work is done, and the diagnosis is confirmed as FPHL. What's the treatment plan look like? Is there a standard approach?
There is. There's a pretty established evidence-based hierarchy. The first-line treatment, the one with the most robust evidence, is topical minoxidil.
That's Rogaine, right?
Rogaine is one brand name, yes. We know the 5% concentration, either the solution or the foam, tends to work better than the older 2% version.
And how does it work?
Well, it's a vasodilator, helps blood flow. But critically for hair, it also seems to help prolong that anagen growth phase and maybe even reverse some miniaturization over time.
Anything people should know before starting it?
Yes, definitely warn people about the initial shedding phase. It's common, usually happens in the first month or two. It feels counterintuitive, but it's actually a sign it might be starting to work, pushing out the old resting hairs to make way for new growth. You have to stick with it.
Okay, so minoxidil is step one.
Yeah.
What if that's not enough, or the hair loss is more severe, or there's clear evidence of that relative hyperandrogenism?
Then you move to systemic options. These are prescription medications taken orally. We're talking about drugs like 5-alpha reductase inhibitors.
Like finasteride.
Finasteride, yes, often used at doses like 2.5 milligram or 5 milligrams daily for women's hair loss, which is higher than the dose for men. Or dutasteride is another one in that class.
And another category.
Antiandrogens. The most commonly used one is spironolactone, usually at doses between 100 to 200 milligrams per day. These directly block the effect of androgens on the hair follicle.
These sound like pretty powerful treatments.
They can be very effective, especially when androgen sensitivity is a key driver. We're citing specific drug classes and doses here because this is about the real clinical approach for moderate to severe cases.
But with powerful drugs come warnings, right? Especially for women.
Absolutely critical point. These systemic drugs, finasteride, dutasteride, spironolactone, carry a significant teratogenic risk.
Meaning risk during pregnancy.
Yes, they can cause serious birth defects, particularly in a developing male fetus. So for any woman who could potentially become pregnant, using these drugs requires absolutely reliable contraception. Mandatory, no exceptions. And that needs to continue for a specific period even after stopping the medication. It's a serious conversation to have with your doctor.
That is incredibly important to emphasize. Okay, beyond minoxidil and these systemic drugs, are there other things people try? Other options?
There are. Low-level laser light therapy, or LLT, you see those caps and headbands advertised. The evidence is, well, it might offer some modest benefit for some people, often used alongside minoxidil. It's generally considered safe.
What about PRP? Platelet-rich plasma.
PRP is interesting. It involves drawing your blood, spinning it down to concentrate the platelets, and injecting that back into the scalp. There's some promising data, but the studies are still a bit limited, and the protocols vary a lot, which makes it hard to compare results. It can be expensive, too.
And hair transplants.
Hair transplantation can be a very effective option for restoring density in areas of significant loss. But, and this is key, it doesn't stop the underlying FPHL process. So even after a transplant, you usually need to continue with medical therapy like minoxidil or maybe finasteride to protect the remaining native hair from miniaturizing further.
So it's often part of a combined approach.
Often, yes. And finally, don't discount lifestyle factors. Supporting overall health supports scalp health.
Like diet.
Definitely.
Yeah.
Ensuring adequate protein, iron, zinc. And managing stress is huge, as stress hormones can absolutely disrupt the hair cycle and exacerbate hormonal imbalances.
Okay, so let's try and synthesize this. What are the big takeaways for you, the listener?
First, hair loss around menopause is incredibly common. You are definitely not alone if you're experiencing this. Nearly half of women deal with it to some degree.
And it's driven by a really complex mix of factors. Hormonal shifts, particularly that changing estrogen to androgen ratio, and potentially metabolic changes within the follicle itself.
Right. And getting a proper diagnosis from a professional is crucial. You need to know if it's FPHL or something else, like FFA, which needs a different, often more aggressive approach because it's scars.
Then checking for those underlying issues. Nutrient deficiencies, thyroid problems, making sure androgen levels are properly assessed, that's non-negotiable.
Absolutely. And once diagnosed, targeted treatment works. Minoxidil is the proven first step. For more significant loss, those systemic anti-androgens or 5-alpha reductase inhibitors can be very effective.
bearing in mind those crucial safety warnings about pregnancy risk.
Exactly. Rigorous precautions are essential there.
So we've covered a lot of ground. Let's end with that provocative thought, building on that newer research about the follicle itself.
Right, that idea of the hair follicle undergoing its own menopause, losing its metabolic energy, maybe struggling with glycogen storage needed for growth.
If that's true, if the follicle itself is running low on energy, it really makes you wonder, doesn't it?
It does. It prompts a deeper question for you to consider. If the hair follicle itself is going through menopause, what other hidden internal factors might be shifting in your body? What could be impacting that cellular energy beyond just the headline hormone changes?
Something to reflect on. Thanks for joining us for this deep dive.